Here I'm going to discuss the thalassemia as well as the sickle cell blood disorders, review their treatment options, and then finally discuss some of the high yield points that you will need to know for your step 1 examination. So just to provide some background information, hemoglobin is a pigmented protein that is responsible for carrying oxygen in the red blood cells. Now there are different forms of hemoglobin that exist in human red blood cells, and you can separate these hemoglobins by electrophoresis. So here we have a gel, and if you load the red blood cells onto the gel and run them on the gel electrophoresis, there is a charge from minus to the positive electrodes, as a consequence of which these proteins, since they have different electric charges, will be separated from each other. And so there are 3 main forms of the hemoglobin that exist in a human body. So hemoglobin itself is a tetramer that is made of 4 subunits. So in an adult hemoglobin, which is predominantly made of hemoglobin A, there are 2 alpha subunits and 2 beta subunits. So hemoglobin A is made of alpha 2, beta 2 subunits and accounts for more than 97% of hemoglobin that is in the circulating blood. Then we have hemoglobin A2, which is made of alpha 2, delta 2 subunits that accounts for 1 to 3% of circulating hemoglobin. And then finally we have hemoglobin F, or fetal hemoglobin, which is made of alpha 2 gamma 2, and it accounts for less than 1% of hemoglobin that is in an adult blood circulation. So fetal hemoglobin, as the name implies, is the hemoglobin that is during the fetal life. But then when the child is born, after the first 6 months, when the hemoglobin F lifespan is over and these hemoglobins are destroyed, the only hemoglobin that is left are hemoglobin A predominantly and hemoglobin A2 after that. And there is some minimal production of hemoglobin F during the adult life. Now, important points that you should know about hemoglobin F is that hemoglobin F has high affinity for oxygen, and thus it will pick up oxygen from maternal blood. So the maternal blood oxygen will be transferred to the fetal hemoglobin, and this is one mechanism through which the fetal hemoglobin can pick up oxygen from the mother's blood. And to understand how this mechanism works, first I would like to review the hemoglobin oxygen dissociation curve. So this is an important curve that you will have to know for your physiology questions. So here it shows you the partial pressure of oxygen in the blood. As we increase the partial pressure of the oxygen in the blood, the amount of hemoglobin that becomes saturated with oxygen increases. So therefore, more oxygen will keep on binding to the hemoglobin, and thus the hemoglobin oxygen saturation curve rise almost to 100%. Now, conditions that will shift the curve to the right, and by shifting the curve to the right, you can see that there is less oxygen that is binding to hemoglobin. So therefore, there would be decreased affinity for oxygen in conditions that shift the oxygen dissociation curve to the right. And these conditions include, for instance, elevated CO2, increased altitude, elevated acidity of the blood, which means there is increased level of H+ in the blood, increased concentration of 2 and 3 diphosphoglycerate, elevated temperature, as well as increased metabolic activity. So if you think of it, increased metabolic activity increases the level of glycolysis, as a consequence of which there would be elevated level of 2 and 3 diphosphoglycerate. There would be more lactic acid production. There would be elevated concentration of CO2, and then there would be elevated temperature. So all these conditions that are associated with elevated metabolic activity will decrease the affinity of hemoglobin for oxygen, as a consequence of which O2 will now be released into the tissues. And that all makes sense. Anytime there is an elevated activity in the muscles or any other tissues, that's the time that hemoglobin will release oxygen. Now, what happens with the fetal hemoglobin is that the gamma subunit does not bind to 2 and 3 diphosphoglycerate, as a consequence of which the hemoglobin oxygen saturation curve shifts to the left. So once again, since the gamma subunit does not bind to 2 and 3 diphosphoglycerate, the hemoglobin oxygen saturation curve of the fetal blood shifts to the left. So this is the hemoglobin F. So in other words, there is increased affinity for oxygen in the fetal blood. And that is the reason that the fetal hemoglobin can pick up oxygen from the maternal blood. And then once again, to remind you, adult blood is alpha 2 beta 2, while fetal blood is alpha 2 gamma 2. So the thalassemia and the sickle cell disorders that we are discussing with you are affecting the alpha and beta chain. So the thalassemia is either affecting alpha or beta, while sickle cell is affecting the beta chain. So next, I would like to review these disorders with you. So first, starting with alpha thalassemia, which is from mutations in the alpha gene that is located on chromosome 16. So we have 2 chromosome 16, and then there is 2 genes of alpha globulin on every one of these chromosomes. So total, we have 4 alpha genes. And so for the same reason, there are 4 different forms of alpha thalassemia that exist, depending on how many gene deletions we have. If there is 1 gene deletion, then this is referred to as alpha thalassemia minima, because these patients have minimal symptoms. They do not usually have any anemia, and their histology of their red blood cells is normal. If there is, however, 2 gene deletions, then these patients can have mild anemia, and then on histology, you will see hypochromic microcytic cells. So hypochromic means that the red blood cells are pale, and microcytic means that they are small. And then in addition, there are target cell-shaped red blood cells that you will see with 2 gene deletions. Next, we have 3 gene deletions, and since there is too little alpha, there would be excess accumulation of beta globulin, and so these patients will start to form beta 4 subunits, and this beta 4 hemoglobin is referred to as hemoglobin H. And these patients will have anemia that is more severe than 2 gene deletions, but it's not severe enough to require chronic transfusion therapy. So in fact, these patients can live the first few years of life without any transfusions. Next, we have 4 gene deletions, where due to the excess amount of the gamma subunits, there would be gamma 4 hemoglobin that will be formed. And this is referred to as hemoglobin Bartz. And these patients are presenting with hydrops fetalis, where there is edema in the fetus, and there is usually intrauterine death. So these patients would not survive birth, and the reason for that is that gamma 4 has extremely high affinity for oxygen, and it won't release it to the tissues. As a consequence of which, once these patients are born, the blood would not be able to release any oxygen to the different tissues, and thus they would die before or soon after birth. Now, one last point that I would like to mention is that patients who have 2 deletions of the alpha gene, depending on where the deletion is, the severity of the symptoms can vary. So if the deletions are on the same chromosome, these are called cis deletions, and these are causing more severe symptoms. And cis deletions are usually seen in Asian populations. On the other hand, if the deletions are on 2 different chromosomes, then it's referred to as trans deletions, which is less severe form of alpha thalassemia and is seen more in African populations. Now moving on to beta thalassemia. So unlike alpha thalassemia, where there is deletion of the alpha genes, beta thalassemia is due to the defects in the mRNA processing. So mutations are usually in the promoter or the chain terminator regions, or for instance, they affect the splicing of the mRNA. So in other words, the mutations are affecting the mRNA processing of the beta chain. And patients with beta thalassemia major are presenting with severe anemia, and so due to the severe anemia, the body will start to make blood in the other tissues, like for instance in the liver, in the spleen, as well as in the skull, or in other words, in the craniofacial bones. And so since there is an expansion of the medullary space of the skull, these patients will have chipmunk faces, where there is prominent frontal and parietal bones, and they would also have crew-cut appearance on the skull x-ray. So let's say that here we have a skull, and then you take an x-ray. On the x-ray, you will see like crew-cut appearance of the bone due to the medullary expansion. And then due to the enlargement of liver and spleen, so due to hepatosplenomegaly, these patients also have enlarged abdomen. Now, one question that I have for you is that why is it that patients with beta thalassemia major are usually asymptomatic for the first 6 months of life? And the answer to your question is that for the first 6 months of life, there is still hemoglobin F that is circulating in the blood, as a consequence of which these patients are asymptomatic. But then after 6 months, the lifespan of hemoglobin F is over, and that's the time that patients with beta thalassemia major will start to develop severe anemia. And then on histology of these patients, you will see microcytic and hypochromic red blood cells. So here you can see that hypochromic, where the red blood cells are pale. They could be microcytic, smaller in size, and they could also be target cell shaped. Now, as for the treatment of patients with the beta thalassemia major, you will have to treat them with the lifelong blood transfusion. So treatment of patients with beta thalassemia major requires lifelong blood transfusions, as a consequence of which, due to the accumulation of iron in the body of these patients, they could develop secondary hemochromatosis. So you may recall that hemochromatosis is a disorder of excess accumulation of iron in the body that is caused by mutation in the HFE gene. Now, patients that have beta thalassemia major, they keep on receiving blood transfusion, as a consequence of which there is elevated iron in their body, so that it will cause secondary hemochromatosis. And to avoid this problem, what you will have to do is to provide patients with chronic blood transfusions with the iron chelators. And can you tell me what's the name of the medication that you use as an iron chelator? So it's deferoxamine. So patients with the beta thalassemia major will undergo lifelong blood transfusion along with iron chelators like deferoxamine to prevent secondary hemochromatosis. Next, we have beta thalassemia minor, and unlike beta thalassemia major, patients with beta thalassemia minor are usually asymptomatic, or they could have mild anemia, but it's hard to diagnose them clinically. And so an important point that you will need to know for your step 1 exam is that in order to differentiate patients that are normal from those who have beta thalassemia minor or beta thalassemia trait is via gel electrophoresis. So patients with beta thalassemia minor have elevated concentration of hemoglobin A2 compared to normal patients. There is also elevated concentration of hemoglobin F, but hemoglobin A2 is more prominent. So this is a very high yield point. Patients with beta thalassemia minor, you can differentiate them from normal individuals by electrophoresis, where there is an elevated concentration of hemoglobin A2. Now, patients with beta thalassemia major also have elevated concentration of hemoglobin A2 and hemoglobin F, but then hemoglobin A, which is alpha 2 beta 2, is absent in these individuals. And that is the underlying cause of anemia in patients with beta thalassemia major. And then one last point I would like to mention about beta thalassemia minor is that on histology, you may be able to see basophilic stippling of the red blood cells. The final topic that we are discussing for this video is sickle cell anemia, and sickle cell anemia is due to the mutations in the beta globulin. So it's not the alpha globulin that is mutated, but rather mutations in the beta globulin, where the glutamic acid amino acid is changed into valine on the 6th amino acid position. So glutamic acid changes to valine on beta globulin, as a consequence of which sickle cell anemia develops. And the definitive diagnosis for the patients with sickle cell anemia is again gel electrophoresis. And so here is an example of hemoglobin S that can be detected in patients that have sickle cell anemia or sickle cell trait, which is heterozygous, while sickle cell anemia is the homozygous form of the sickle cell. So both beta genes have mutations in the homozygous form, as a consequence of which the hemoglobin A band would not be present in these patients. And then as for prevalence of the sickle cell trait and sickle cell anemia, as high as 8% of US African Americans have sickle cell trait, while 2% of US African Americans can have sickle cell anemia. Now, important features that you will need to know for your step 1 exam is that dehydration or deoxygenation of the hemoglobin will cause sickling of red blood cells, as a consequence of which it will cause vaso-occlusive crisis, where there would be severe pain in the chest and digits. So here on histology, you can see that there is this sickling of red blood cells. And so a live example of vaso-occlusive crisis that I had while I was on my pediatric rotation was a child that was like maybe 3-4 years old. She wouldn't talk to me but was telling her mom that she has pain in her hands. So while I started examining her, as soon as I touched her fingers, she started crying. So patients with sickle cell anemia can have severe pain in their digits from vaso-occlusive crisis, and it's more commonly seen in African American patients. Now, once again, I have a question for you, and it's that why is it that newborns are generally asymptomatic? And then the answer is written right in front of it, because there is hemoglobin F up to 6 months of age. So similar to beta thalassemia major, patients with sickle cell anemia can be asymptomatic for the first few months of life. Now, as for the treatment of sickle cell anemia, you can treat these patients with the hydroxyurea. And what hydroxyurea does is that it increases the production of hemoglobin F in these patients. And then the other treatment option is bone marrow transplant. And then there are some other high yield points that I would like you to know regarding sickle cell anemia, and after that this video will be concluded. So important to know is that due to recurrent thrombosis and infarction of the spleen, these patients will have autosplenectomy by about age 5. As a consequence of which, since there is now no more spleen in patients with sickle cell anemia, therefore they are prone to infection by encapsulated bacteria. Now, osteomyelitis by salmonella is more commonly seen in patients with sickle cell anemia compared to the general population. And the reason for that is that, one, these patients have asplenia, which makes them susceptible to encapsulated bacteria like, for instance, salmonella. And two, due to the infarction of the GI from the microvascular occlusions, there would be release of the salmonella into the human body system, as a consequence of which now there is increased risk of osteomyelitis. Now, one important point that you should know is that Staphylococcus aureus, so Staphylococcus aureus, is the #1 cause of osteomyelitis in general population. So in patients who have sickle cell anemia, Staphylococcus aureus is still also the #1 cause of osteomyelitis. And then after Staphylococcus aureus, it would be salmonella. That would be the next more common cause. So if on the exam you have a question where there is a patient that have pain in the digits, you notice chipmunk faces, which is another feature that can be present in sickle cell anemia. You do more testing, whether it's the histology of the red blood cells that give away the diagnosis, or whether you do electrophoresis that gives the diagnosis of sickle cell anemia. And then the question asks you, osteomyelitis by which of the following infectious agents is more common in these patients? If you have both Staphylococcus aureus and salmonella among your answer choices, then you have to first pick Staphylococcus aureus. And if Staphylococcus aureus is not there, then go ahead and pick salmonella as your next choice. Another important point regarding patients with sickle cell anemia is that they can develop aplastic crisis upon infection with parvovirus. And so the reason for that is that parvovirus decreases production of red blood cells. And since patients with sickle cell anemia are already dealing with anemia, therefore from decreased production of the red blood cells, there would be aplastic crisis, as a consequence of which these patients will have increased fatigue, pallor, exercise intolerance, as well as shortness of breath. Now, one question that I have for you is that parvovirus in children, it can cause slapped cheeks with fever, and that is high yield. So what's the name of the disease that is caused by parvovirus presenting as slapped cheeks and fever? So that is called fifth disease. And in patients who have sickle cell anemia, it can cause aplastic crisis. The last point I'd like to mention is that patients who are heterozygous for the sickle cell, in other words, those who have sickle cell trait, are protected from malaria infection. And the reason for that is that as the Plasmodium falciparum parasite infects the red blood cells, it will cause sickling of those red blood cells, and these sickle cells are now targets of phagocytes. and so they would be removed now from the circulation. So therefore, patients who are heterozygous for the sickle cell are protected against malaria. And that concludes our discussion of the thalassemia as well as the sickle cell blood disorders.